Cryptococcus infection reminds us of HIV positive patients, and heart gave us the hope that we won't be seeing much number of these cases anymore. But WHO fungal priority pathogen list published in October 2022 changed the scenario. Cryptococcus neoformans tops the list out of these 19 important neglected fungal pathogens, where it holds the top position for highest mortality in sub-Saharan countries. At the same time, Cryptococcus geti also holds a position among medium priority group with a lower mortality rate. Though there is a decline in incidence of cryptococcal meningoencephalitis in sub-Saharan Africa with the expansion of heart in AIDS patients, right from 960,000 patients in 2007 to 150,000 in 2020. There is a redistribution of this incidence with doubling of numbers in Europe and North America. But there is a disparity in the mortality rate in these two parts of the world. In resource-limited countries, it remains 41 to 61%, whereas in developed world, it is just 5 to 15%. Besides this, there have been reports with rare hepatic cryptococcosis mimicking a metastatic liver cancer in an immunocompetent patient. Another, Cryptococcus neoformans endocarditis in an immunocompetent patient. Emergence of cryptococcemia in COVID-19 infection. Prosthetic joint infection. Osteomyelitis of the tibia, and osteomyelitis and intramuscular abscess in a liver transplant patient. So such case reports in recent times has put Cryptococcus neoformans again in the spotlight. Let's have a look at its epidemiology. It is a ubiquitous yeast present worldwide, but there is an association with different types of vegetations like mopane tree, river red gum, also known as Eucalyptus camaldulensis, conifers, Douglas fir, and also pigeon droppings. Though there has never been any outbreak associated with pigeon roosting places. Cryptococcus geti, which was localized in northern Australia and Papua New Guinea, associated with eucalyptus trees in rural parts of the country, has redistributed itself with global warming to Northwest Pacific. And here it has caused outbreaks since 1999, especially in immunocompetent people. The infection is acquired by inhalation and it gets lodged in the lungs, and there it is contained in granulomas, where it remains latent, just like tuberculosis or histoplasmosis, contained in these granulomas for the lifetime. It's only in certain adverse circumstances it flourishes and disseminates, especially to CNS system. It is a neurotropic fungus. So besides host immunity, the fungal inoculum size matters, and also strain virulence as seen in Cryptococcus geti outbreaks. The predisposing factors are major T cell immunodeficiencies. The HIV AIDS forms the largest contribution of patients. 19% deaths in AIDS patients is because of cryptococcal diseases. But recently, with a larger emerging immunodeficient population worldwide, has shown us that these other conditions, that is malignancy, solid organ transplant, corticosteroid use, diabetes mellitus, chronic liver and kidney disease, multiple sclerosis, idiopathic CD4 cell deficiency are major contributing factor. Even in pregnant women during third trimester, there have been cases with iris manifesting postpartum. Interestingly, cryptococcosis doesn't affect children so commonly. Clinical manifestations. So lungs are the primary organs of infection, and there can be pneumonia right from asymptomatic to acute infection to chronic and ARDS, acute respiratory distress syndrome. And they all can manifest in non-HIV, non-immunocompromised patients. Many a times, a very well-defined nodule is present in lungs, which is diagnosed radiologically incidentally. And it is usually thought to be a malignancy or a spread of malignancy, but on histopathology, then cryptococcal yeast cells are found. Of course, cryptococcal meningoencephalitis is the main presentation and dreaded complication of this infection. Cryptococcomas are now reported, and it involves CNS as well as lungs. And Cryptococcus geti is more commonly responsible for this kind of presentation, especially in immunocompetent patients. Skin is next site where it can manifest as papules, plaques, cellulitis. Papules in HIV patients mimic molluscum contagiosum. And when any single distant site is involved, it is called as dissemination. Prostate is the site where the fungus gets sequestered and is responsible for relapses. The high mortality is due to delay in diagnosis, especially in resource-limited countries where lumbar puncture is not feasible, and even serological tests are not easily available. Lack of intensive care, because these patients need during their induction phase intensive care and monitoring, so they are not available in developing part of the world. Then increased intracranial pressure, especially responsible in acute condition for higher mortality, and it needs careful monitoring and management. The treatment approved by various societies is costly and toxic and not readily available. And there is immune reconstitution inflammatory syndrome responsible for some number of deaths in these cases. There are two clinically important species, Cryptococcus neoformans. Recently, it has been renamed as D. neoformans, and it is the most common species, because usually labs are not differentiating or identifying the species in most of the parts of the world. And so we always call them Cryptococcus neoformans, and they are responsible for higher mortality as well. So there is a difference of almost 3 to 4 times higher mortality in neoformans than Cryptococcus geti. So we have seen Cryptococcus geti has redistributed itself from tropical, subtropical areas to even temperate regions, and there it has led to outbreaks, and it has been found that anti-GM-CSF antibodies are present in these immunocompetent people getting this infection. Why it is less identified? Because it needs special media cannavanine, glycine, bromothymol, blue agar for identification, on which it produces cobalt blue color colonies, and it is because this fungus is resistant to cannavanine. It can also be differentiated from Cryptococcus neoformans on the basis of multi-TOF or PCR tests. So it is mostly responsible for infection in immunocompetent patients, and it produces cryptococcomas more commonly. It needs prolonged induction phase of therapy. So there are numerous virulence factors in this yeast, and polysaccharide capsule of gluconoxylomannan is a very important marker. Another important marker is phenol oxidase, which is responsible for its CNS involvement, and then there are others. So for laboratory identification, for past so many decades, India ink preparation remained very important test in resource limited countries, where one can find these capsulated budding yeast cells in CSF and even in BAL samples. And there is a very striking feature that there is variation in size in these yeast cells, because young budding daughter cells, they separate from the mother cell at a very early stage. So that is important to differentiate it from blastomycosis. And one should know that it is a subjective test, and it has a good sensitivity, that is 70 to 100% in HIV patients, but in immunocompetent patients the sensitivity is only 50%. But where antigen identification tests are not available, it can still be used easily and simply with a rapid turnaround time of the test. Culture remains the gold standard. It easily grows on routine media, though cyclohexamide is inhibitory. Quantitative culture is now the norm, and 100 microliter of CSF should be inoculated on the plate, and the reports usually come after 3 to 7 days. Therefore, these rapid microscopy and serological tests remain important, and multi-TOF can identify the species. So we know capsulated yeast isolated from CSF, urease positive, indicates towards Cryptococcus neoformans. The other important conventional test is melanin production on bird seed agar, and histopathology remains important in biopsy material, and mucicarmine stain, Elchin blue stain, specifically stain the capsular material, and Fontana Mason stain stains the melanized yeast cells. So antigen detection has become center stage, and earlier latex agglutination tests or enzyme immunoassay were available, and they were known as CRAg. But now lateral flow assay has emerged and has become very important test for screening and diagnosis of these cases. So it detects capsular antigen, and it is so sensitive that it detects before the beginning of any symptoms in HIV positive cases. So it is used for screening these patients when CD4 count falls below 200. It is highly specific and efficient, but it is not useful for follow-up because it can remain positive for a long time. But if we see a fall in the titer, it can be quantitated. So it can indicate improvement in the patient. So it's a point of care test because it can remain at room temperature and it can be applied to various samples. but its utility is limited in immunocompetent patients who are usually diagnosed with the help of culture or PCR. But remember, even culture and PCR uh, have this disadvantage of low sensitivity because of low fungal burden. So in AIDS patients or HIV positive patients, diagnosis goes by this algorithm. The neuroimaging is performed to see whether lumbar puncture is feasible, and then opening pressure should be recorded, and it should be monitored and managed properly, which is very important for long-term neurological sequelae and imminent blindness in acutely infected patients. And the CSF sample should be sent for lateral flow assay if it's not available, India Inc. and culture. So if lumbar puncture is not available, LFA should be performed on whole blood or serum or plasma, or even in urine sample it can be done. Management. So as we have seen, it's very important to maintain intracranial pressure below 200. Whether a patient needs a repeated lumbar puncture or needs a ventriculoperitoneal shunt, that should be seen and advocated. Then one should know that echinocandins have no role in this infection. It is intrinsically resistant. There is some acquired resistance seen to fluconazole where it has been used uh, prior because of as prophylaxis. Then heteroresistance and transient tolerance is commonly seen. Neurazoles are effective, but there are more studies are required, and the treatment approved is toxic and costly. So there are three phases of treatment for severe infection, that is cryptococcal meningoencephalitis, severe pulmonary or disseminated infection. So an induction phase of 2 weeks, consolidation phase of 8 weeks, and maintenance phase of 12 months. Now, induction phase should be very carefully planned and monitored because the final outcome depends on induction phase going smoothly. For moderate pulmonary diseases, fluconazole 400 milligram is required for 6 to 12 months. So we will see how these three phases of treatment are instituted. So induction phase has been managed by WHO in 2018 guidelines by for first week giving IV amphotericin B along with flucytosine, followed by in second week fluconazole 1200 milligram per day in adults. Recently, there has been a study where WHO has released a guideline in 2022 by non-inferior and fewer side effects in this study with this regime. So there is a single high dose of liposomal amphotericin B is given only once at a dose of 10 milligram per kg body weight, along with flucytosine and fluconazole for 14 days. So this has fewer side effects because of amphotericin B, but a single dose is effective because of its long half-life. Consolidation phase is with fluconazole at a higher dose for 8 weeks, and then maintenance phase is up to 12 months with 200 milligram per day in adults, and there is a lower dose in children. It's very important to monitor renal clearance with all the three drugs in these patients, and accordingly dose should be adjusted. Complications. So immediate complications are blindness and neurological sequelae, and therefore intracranial pressure should be reduced and monitored regularly and adequately. Iris immune reconstitution inflammatory syndrome is seen at 2 to 4 weeks of treatment. Therefore, heart should be started ideally at 5 weeks in these patients on treatment for cryptococcal meningoencephalitis, and it needs to be differentiated from relapse. So PCR test is ideal because it will provide reports immediately, and PCR would be negative in a case of iris and positive in a case of relapse. These patients need pulse corticosteroids because there is an associated mortality if not managed well in time. Now remember, steroids are bad for invasive fungal infections. In fact, all fungal infections. There are only few situations like PCP in HIV patients and iris in cryptococcal meningitis and uh, meningitis by Cryptococcus gatti in immunocompetent people. Only these three groups show improvement with steroids. Otherwise, steroids will worsen the invasive fungal infection, including fungal keratitis. Relapse, usually if induction phase has been smooth and adequately treated, relapse doesn't occur. But if relapse is suspected, PCR or culture will be more helpful. And remember, PCR has low sensitivity because it's difficult to break down the E cell to release the DNA. Similarly, culture in a treated patient will take 10 to 21 days because of low level of resistance. Um, and uh, One needs to differentiate it from the iris. So there are almost 1,12,000 deaths annually due to cryptococcal disease, and there is a vast difference in resource limited countries from the developed world. With adequate information, proper diagnosis, early diagnosis, and proper management of cases, we can decrease these deaths. And we should go through these studies which enlighten us further on this topic. Thank you.